Good afternoon, everyone. My name is Dr. Anita Munoz, and I'm presenting to you on managing stroke survivors in the community. I'm here in my capacity as a clinical editor working on the HealthPathways program for North Western Melbourne PHN. I'm also a GP in Melbourne CBD, and I have a role as a medical educator involved in teaching general practice registrars. What I wanted to take you through is just the learning objectives and what I intend to talk to you about today. First of all, post-stroke care is quite a complex topic, and one of the things that makes this difficult in the community and for general practitioners is appreciating the biopsychosocial challenges that our patients have to deal with once they've had a stroke. So being able to describe those challenges is the first step in being able to manage them effectively. We are also going to look at effective use of a post-stroke checklist, which is a way for practitioners to work their way through complex consultations with stroke survivors. Of course, we're going to then move on to listing the people that are involved in the care of stroke survivors in the community, both practitioners and services. And describe a framework for those services and practitioners to cooperate together so that we can achieve the best possible outcomes for our patients. And then finally, I am speaking to you today in my capacity as an editor on the Health Pathways program, and I'll explain to you how Health Pathways can be used as a clinical tool to assist us in managing our post-stroke patients. So I guess one of the questions is, why would I focus on stroke rehabilitation if I'm working for a PHN as a clinical editor, educating GPs? Why would I focus on stroke rehabilitation? And I guess the answer to that question is that there are many Australians that are affected by stroke each year, the 48,000 in fact. And what we know is roughly 1/3 of those people who suffer stroke will go on and have disability and loss of function. That actually equates to around about 16,000 people per year, and those people continue to suffer the effects and the sequelae of their stroke year after year. So the disease burden that's associated with stroke is actually quite high. One of the concerning statistics too is that if you have a stroke, almost half of the people that have their first event will go on and pass away within 5 years of having their initial stroke. So we know that this can be the beginning of a life-ending event for people. And so the focus on stroke rehabilitation is not only to improve people's outcomes as far as managing their disability and managing their quality of life, but actually to try and reduce the number of people that go on and die as a result of having that first event. The other reason why stroke rehabilitation is an important focus is because it's actually quite common. If we look at what happens in general practice, 2 in every 1,000 encounters has something to do with stroke, and that's actually quite a reasonable amount. It equates to around 240,000 consultations that are conducted in the community every year. So this is a reasonably common problem. It gets seen a lot in the community, and certainly we can maximise how effective we are at doing this work if we have an effective framework. One of the things that can make post-stroke care difficult is its complexity. And partly what makes it complex is that the agenda for the post-stroke consultation changes depending on where you are in the patient's journey. So it tends to get divided up into the following way. There's the immediate post-stroke care, and then there's post-stroke rehabilitation care. So when we talk about immediate post-stroke care, that should be a consultation that is done basically within the first 2 weeks of a patient being discharged. And in an ideal world, and certainly what's been written into the pathway that has been published, is that upon receipt of a discharge summary, ideally a clinic would actually call a patient and make sure that that immediate post-stroke consult has been booked. And of course has been booked for a long period of time, usually 30 minutes, because there's a lot of things that need to be worked through in that initial consultation. And it also needs to be made clear that in the initial consultation, you're probably not going to be dealing with stroke rehabilitation matters. But what you're going to be doing is attending to the person's capacity to survive and continue surviving the risk that has now declared itself. So basically, the GP and the practice nurse, usually working together, are going to try and help that stroke survivor with things like blood pressure lowering, smoking cessation, making sure that they've started and they're on antiplatelet therapy if that's appropriate, deal with cholesterol, deal with other risk factors like diabetes, and of course not overlook the issue of AF and carotid artery stenosis. Once those issues are in train and the GP is working with the patient to get towards target, the next set of consultations that are done can focus a little bit more on the stroke rehabilitation agenda. And what's generally recommended is that the post-stroke consults, where we're dealing with the rehab issues, are conducted at 3, 6, 9 and 12 months after the initial event, and then they occur yearly thereafter. And of course there's a caveat on that advice in that if patient or practitioner identify that there's a need for more frequent reviews because of tricky issues with disability or with rehabilitation, of course you can be doing these consultations more frequently if needs be. And the reason why we focus on post-stroke care is because we know that it actually improves patient outcomes. So if we do things like aggressively manage our secondary prevention, then the chances of our patient going on to be one of those 45% that dies within the next 5 years actually lowers. For example, if we start antiplatelet therapy, just doing that alone will reduce the risk of recurrent stroke by 13%, which is a significant reduction. But of course, often patients need a lot of encouragement and help to stay on their medication, to understand what they need to be taking and the reason why they're taking it. And so regular contact with the patient to check on their compliance is a great way to make sure that we're managing the secondary prevention, because there's a lot of evidence that that's going to improve outcomes for our patients. But it's not just about secondary prevention. In fact, when it comes to the post-stroke consult, secondary prevention is only one of 13 matters that may be dealt with in that consultation, and I will get back to that in a minute. There are really important things that affect a person who is rehabilitating from the stroke. And things like managing depression can have an enormous impact on a patient and their loved one's experience post-stroke. What we know is that depression has a negative impact on function and cognitive recovery. And depression affects somewhere between 23 and 40% of stroke patients. So it's a very common sequelae for patients to experience problems with their mood post-stroke. There have been 4 RCTs that have demonstrated that treating depression improves functional outcomes, not just mood and cognitive outcomes. Can also help with a person coping with their activities of daily living and with their neurological recovery. Although I will add that the researchers who completed those RCTs have indicated that more research is required in that area. We also ask patients, and I hope that we will ask patients as a result of this discussion today, about delicate matters like their sexuality. The reason for that is we know that 58% of males and 44% of females report dissatisfaction with their sexuality post-stroke. And that's comparable to pre-stroke dissatisfaction of 21 and 20% respectively for males and females. So what that's saying is that we know that stroke causes much higher rates of sexual dysfunction than it does affect the population before an event like that happens. We also know that often patients won't bring up this aspect of their life and their quality of life, often because they perceive that nothing can be done about it, or they may perceive that the issue has no solution, and they also may avoid discussing it out of embarrassment. And so I think it does fall to the practitioner to bring this topic up on behalf of the patient and invite a discussion. And of course, it seems pretty obvious to say that if you're going to invite a discussion about a topic like sexuality post-stroke, you need some information and some framework about how to approach this problem if your patient does identify that they're having trouble. And we're going to go through an approach to that in a minute. I would just like to draw some attention to the important topic of post-stroke fatigue, because I think that this is often poorly understood in the community, just what an impact post-stroke fatigue has. And I think sometimes we don't even recognise it as an entity. But certainly post-stroke fatigue occurs in between 30 and 60% of post-stroke survivors. And more importantly, our post-stroke fatigue can be managed. So if a patient is reporting that they are tired and that that's impacting on their quality of life, then acting on that fatigue will actually improve the symptoms. It's not something that needs to be put up with. And finally, I also think that cognitive and behavioural changes often get thought of a little bit like the fatigue, that they're expected and that nothing really can be done to help with those kind of stroke side effects. And that also is erroneous thinking, because we do know that going on to offer patients help with their cognitive functions and also with their behavioural issues really does have an impact on their quality of life and that of their carers as well. But again, it all rests on having a framework and knowing what you can do to offer someone some help if they identify with having a problem. So at this point, I would like to introduce you, for those who aren't aware of what HealthPathways is, to the program that is HealthPathways Melbourne. As I've mentioned, I'm a clinical editor and I work on this program on behalf of Northwestern Melbourne's PHN. And we have purchased this program from New Zealand, where it originates. Basically, HealthPathways is an online portal. So it's a tool that gets used at the point of care by health practitioners. Its use is limited to health practitioners because that is the audience that it is targeted at. So it's not written for a tool for the lay person, although I will show you that there are lots of resources that can be used when you're communicating with patients and with lay people. Basically, HealthPathways is written by GPs like myself to be used primarily by GPs out in the community. But it is an enormously helpful and important resource for all types of health practitioners. And what it actually does is it divides a pathway into 3 sections. It's a guide, a summary of best practice when it comes to assessment, management, and then also referral practices when dealing with common and also not so common medical, surgical and psychiatric conditions. And the content of HealthPathways is informed by subject matter experts that we interview and collaborate with in order to make sure that we have the best summary of best practice guidelines regarding whatever topic it is that we're dealing with at the time. So HealthPathways as an online resource, basically, apart from providing the guide to evidence-based management, probably its genius is in that it summarises all of the available secondary and tertiary services that exist within a catchment. So not only is the practitioner getting a reminder and some help with the assessment and the management of a condition, but also has a one-stop shop, for want of a better word, that describes all of the available services, how to refer and when to refer appropriately, and also what information each service requires in order for that referral to be successful. And as you can imagine, in the stroke rehabilitation space, giving a GPs in particular a guide to how to refer effectively, particularly to services such as stroke rehabilitation, can really streamline and improve the way that a patient journeys through the health system. It certainly improves communication between GPs and allied health practitioners and specialist colleagues. And it makes the patient journey a little bit more predictable and understandable for all of the people that are involved. Because there's been an agreement from specialists, allied health and GPs who have all contributed to writing the pathways about how we want to best manage our patients in our catchment. The stroke rehabilitation pathway was written from scratch by North-Western Melbourne PHN, myself and my team, because we recognised that when dealing with stroke, the acute stroke phase is a very different one to the stroke rehabilitation journey that a patient goes on. And we thought that it was most appropriate to create a pathway that describes stroke rehabilitation as its own entity. And in actual fact, given how complex stroke rehabilitation is, the pathway is working very well because it's providing a framework for GPs to navigate the complex presentations that post-stroke patients come in with without having it buried within the acute stroke agenda. And keeping the two consults separate, I think, is a way that helps GPs not overlook some of the important aspects of post-stroke rehabilitation care. So we divided up the pathways, in other words, to the acute stroke pathways, which, as you can imagine, deals with acute stroke presentation, and then the immediate stroke aftercare. And then we devoted an entire pathway just to rehabilitation, which is what happens from 3 months onwards for our stroke patients. The pathway gets written by a person like myself, a clinical editor, working in conjunction with a clinical working group. And this clinical working group was comprised of rehabilitation physicians. We had 2 GPs advising us, and then we drew together a wonderful bunch of allied health practitioners who gave us very practical advice about how to manage many of the issues in stroke rehab. So namely, we had physiotherapists, occupational therapists, neuropsychologists, and a speech pathologist. And we sat down in a room and decided what would be the best way for GPs in our catchment to manage their stroke rehab patients. And then we published the consensus on the HealthPathways portal. The group, when it got together, we decided to list our objectives and what it was that we wanted to achieve with our pathway. And basically, we wanted to give GPs an agenda and then a framework for working through post-stroke consultation. We also wanted to design a useful checklist. And the reason that we wanted to use a checklist is because if a patient identifies only a certain number of problems, the GP can devote their entire time to the problems that have been identified. So the checklist does 2 things. It identifies what it needs to be done at the consult, and it also tells the GP what things they don't need to spend their time on that particular time round. So it makes for greater efficiency for the GP, but also for the patient to communicate to the GP what it is that they need help with on that particular day. Of course, the group also wanted to summarise the evidence, and we've done that, and we have given to GPs a list of the evidence on the pathway, and we also wanted to summarise the services. So the reason for doing all of this is that GPs then are delivering timely care in a meaningful way for their patients so that they can access the services that they need in order to improve their outcomes. I'm going to talk just very briefly about the post-stroke checklist. Most people who are involved in stroke care are aware of the WHO checklist, and our group drew on the WHO post-stroke checklist to improve our patient care. And what we decided to advise GPs is that to use their practice nurse to make their stroke rehab work as efficient as possible. So the pathway advises their GPs to get the nurse to spend some time with the patient using the checklist to identify which of the 13 areas that patient needs help with. So ideally, the patient will be booked in with the nurse, usually for 20 or 30 minutes, to go through the checklist. We also advocate that the nurse goes through a depression scale each time with the patient, and this sets up the consultation with the GP. Once the GP then sees the patient with the checklist, that will inform what the GP is going to do with the patient during that consultation. And as you can see, the checklist involves 13 points that can be discussed with the patient. Usually a patient will only need to discuss a few of that list, and it would be very unusual for a patient to have to discuss all 13. So I'll just go through the way that the checklist was designed. We carefully constructed and deliberated over these questions, because what we wanted was for the user to understand what we were trying to get at, and we wanted to make it very easy for the patient to answer yes if they did have a problem. So we discussed during the clinical working group the best way to pose our questions, and the questions read as you can see on the screen. For example, with communication, since your last stroke review, are you satisfied with your ability to communicate with others? So if there's any dissatisfaction or a patient feels like things aren't going well, it's easy for them to answer yes, and that will indicate to the GP that communication is one of the topics that needs to be discussed during that consultation. I'm just responding to a question here from Michelle, who asked me out of interest, is number 8 supposed to say dysphagia swallowing as the next point? Is that communication dysphagia? And yes, Michelle, that would be a typo that I must have on that slide. So thank you for asking that question to clarify that. Of course, because we're dealing with post-stroke patients, we have to bear in mind that many of that population can be affected by aphasia. And so we worked with specialist speech pathologists who work in the stroke area to create an aphasia-friendly checklist. The checklist, both the written format and the aphasia-friendly checklist, can be printed from the HealthPathways website so that it can be used directly from the computer. The nurse can print it out in preparation for the consultation with the GP. So everything that's found on the HealthPathways site can be printed, including resources, which I'll get to a little bit later. Now, because this discussion we're having today is about the management of post-stroke patients, not so much the assessment, I'm not going to go into the assessment area of the pathways, but I certainly would encourage you all to have a look at it and see what advice we've decided as a group to give GPs about how to assess each of the 13 points that I've listed. But in the interest of time, we're going to spend more time about managing stroke patients rather than assessing them. But I would like to just draw you to a couple of points in the assessment which I think are interesting to indicate to you how the pathway actually works. For example, when we're talking about communication, and I apologise that it may be difficult to read the words on that slide, but if you can see the area about communication in assessment, we've embedded useful tools for the GP into the pathway to make it easier to communicate and understand what a stroke survivor may be wanting to tell them. So we use a visual analog scale, and again this can be printed from the website so that a GP can assess communication and assess what a patient is trying to tell them about things like pain and fatigue and spasticity using a visual analog scale if communication is difficult. We also embed in the assessment area a tool for assessing mood, and that tool again can be printed by the nurse and used at each consultation with the patient to assess if there's any issues with mood before the patient sees the GP. If something has been identified that needs attention, then the GP can go into greater detail with the patient at the time. So I'm going to move on from assessment now and start talking about management, because this is really why we're here. We're wanting to discuss how can we improve the management of our post-stroke patients as a community. And when I say as a community, I mean GPs working with allied health practitioners, working with specialist colleagues, and working with tertiary services. And I will go through each of the 13 management points in turn, because I think it's important for us to have a framework for addressing each of the difficulties that a post-stroke patient may identify as having. First one is secondary prevention, and really this is for GPs to make sure that they're keeping their patients to target. And we do ask if the patient is having trouble keeping themselves to target with their blood pressure, if they're taking their medication, and if they need any assistance with either of those things. So that's asked about each consult. If the patient identifies that there's a difficulty there, then the GP has a summary of the evidence of what targets need to be achieved in order to help manage stroke risk and further stroke risk. The second thing that we ask about in the post-stroke checklist is mobility. And we screen for mobility in general practice. We decided that the simplest way to screen is to do the up and go test, in which a patient stands up from a chair, walks, turns around and returns to the chair. And if mobility is found to be a problem and it's assessed and the GP says can identify that mobility is a problem, then we direct the GP to a series of actions that should be taken as soon as the problem is identified in order to help the patient with the mobility issues. And as you can see on the screen, often what this involves is a coordination of timely referral to the allied health practitioners that are needed for that particular issue. So here we've got the GP being directed to refer to an exercise program, and also not to overlook things like testing for visual impairment, and also having a check of medication and medication lists to look for polypharmacy, all of which can impact on somebody's mobility. We also remind the GP not to overlook the issue of osteoporosis, because obviously with mobility problems comes falls problems, and osteoporosis can contribute to disastrous outcomes should the patient fall. Moving on to falls, the way that we assess for falls once the patient has identified that they are concerned about falling on their checklist is by asking questions about things that make them at risk of falls, risky habits or obstacles at home that need to be managed. If the GP thinks that there is a problem with falls, then they provide information and education about reducing the chances of falling at home, and then are also directed to consider referral to falls and balance clinic. One of the topics that I think can be quite difficult for GPs to manage in the community is that of spasticity. And there's a couple of reasons why that is. First of all, spasticity can be difficult to understand and to ask about unless you know what you're asking for, and unless you know what you're going to do about what you find. So we ask GPs to examine areas of the body that are experiencing spasticity, and ask the patient if they're having trouble with spasticity and its impact on their ability to conduct their ADLs. What we don't ask is for GPs to become experts at treating spasticity, certainly not initiating antispasmodics. What we're wanting the GP to do is to find the problem, name it, and then get the appropriate help in a timely manner. And as a clinical working group, we decided that it would be appropriate for GPs to up-titrate antispasmodics, but the initiation of medication like that is probably best done by a rehab physician. And of course, one of the most important things to manage spasticity is to recruit the help of either a physiotherapist or preferably refer that to community rehabilitation. One of the important messages that I think the pathway gives to GPs and hopefully to all people involved in post-stroke care is that a person who's had a stroke may continue to have problems with a particular area of their care indefinitely. But even though that person continues to have a problem, it's not inappropriate to continue to refer back to allied health or to rehab to manage that problem. So if the person continues to identify spasticity as an issue for them at each yearly check, then we do want GPs to continue to refer back so that there's an ongoing management of the problems that get identified, not to simply attempt to treat the problem once and then leave that issue and not keep going back to it. Pain is also a really difficult topic with post-stroke management. I think that this is poorly understood and in many ways we don't need GPs to be experts at understanding all of the pain syndromes that are encountered in post-stroke care. What we do want is to ask the right questions. If there are complex regional pain syndrome or central pain or hemiplegic shoulder pain, then it's a trigger for a GP to call on help in a timely fashion. It's not considered necessary for the GP to single-handedly manage these complex pain syndromes. Certainly we do give advice about managing shoulder pain, and we certainly give advice about simple medications that can be safely used in the post-stroke space. But over and above that, it's entirely reasonable to be calling on specialists and allied health colleagues. And I am being asked where OT, Blake and are being asked to comment on where OT have a role in recovery. Certainly our occupational therapists are involved in managing spasticity, in managing ADLs, and probably as we work our way through the pathway, we'll see how OTs have been written into this pathway to help with quite a few of the post-stroke issues. With fatigue, I think fatigue is also a pretty tricky entity to be understood and managed in general practice because, as I mentioned earlier, there's almost an acceptance that if you've had a stroke, you'll probably be fatigued. What we're wanting GPs to do is not accept fatigue as part of the post-stroke journey, but to try and treat it. And we know that referring back to rehab can improve, if not eradicate, post-stroke fatigue. Post-stroke fatigue is actually quite common, and it can have a really large impact on people's activities of daily living and quality of life. But in order for GPs to work collaboratively with their rehabilitation colleagues, the pathway asks the GP to screen for other things that could be contributing to that person's experience of being tired. And so things like depression, underlying cardiovascular disease, side effects of medication, certainly sleep disorders, which can become quite prevalent in post-stroke patients, and also consider things like energy expenditure, and that's certainly an area where occupational therapists can play an enormous role, is helping patients with aids and to manage their energy expenditure, especially when they're going about their ADLs or simply walking. Incontinence is a pretty important issue too, and the pathway gives GPs basically a framework for dealing with incontinence, and that's something that does get managed basically very well in general practice. Often there's referral to incontinence clinics if the problem is more difficult to manage than what can be done just in the community. So when I talk about the dysphagia part of this pathway, what I'd like to draw your attention to here is the way that the pathway functions to draw GP's eyes to the referral section that will then give them a summary of all of the services that they can use when they're trying to manage a patient's problem. As you can see, it's catchment specific, so you click on your particular catchment and then you will get a list of options, both private and public, for whatever service it is that you're interested in. So for example, with dysphagia, pardon my typo here again, thank you. With dysphagia, we need a speech pathologist, and often GPs mightn't have an idea about where to get a good speech pathologist who's experienced with the post-stroke patient. So that's been summarised within the pathway. So it's just literally a couple of clicks away, and the GP will be able to identify a practitioner who can help them with that particular problem. And just in response to Sharon, thank you for your comment. My typo there for the dysphagia, it should read dysphagia, so my apologies to you all. Now, with communication, the communication can be a major barrier, of course, to being able to effectively manage a post-stroke patient. So we encourage GPs to ask patients if they're frustrated with their ability to communicate, and we ask them to continue to return their patients to Allied Health for help in order to improve their functional capacity and their ability to communicate. So speech pathologists can be very helpful in assisting patients and their carers with their communication difficulties, and you don't need to only refer once. As I've mentioned earlier, we do ask GPs to keep looking at this checklist at least on a yearly basis, if not more frequently, and if the problem continues to exist, then to continue to offer management, because we know that ongoing improvement can occur throughout the post-stroke journey, not just in the few months after the patient has recovered from the initial event, but improvements can continue to occur over years. In response to Lisa's question about how do you determine suitably qualified health professionals, for example, the Speech Pathology Australia database, yes, that's how we do. Speech Pathology Australia is the database that we refer to. HealthPathways is not able to nominate particular practitioners, so we rely on the databases of governing professional bodies to help GPs do searches to find appropriate qualified health professionals. So we tend to link to the search engines from those professional bodies, and that's how it's done. We're going to talk about mood. I think mood is an extremely important issue for our post-stroke patients, and up to 60% of post-stroke patients will experience problems with mood, and it will affect things like their ADLs and their cognition. We know that this is a hugely important topic, so much so that we encourage GPs and all the practice nurse to be offering a depression scale to each patient each time they visit. The reason why I want to draw your attention to the management of mood here is not so much to tell you all how to manage mood, because I think that we recognise that it's a combination of starting medication appropriately if warranted, and there's a lot of evidence that starting medication in post-stroke patients remarkably improves their outcomes. And of course we do know that referral to a psychologist is enormously beneficial. But what I'd like you to be aware of is that the pathway embeds into its content a lot of advice for GPs about how to offer support for the stroke patient. That includes things like Stroke Foundation's Enable Me portal, which is a fantastic resource for stroke survivors to use and offers a community forum as well as information about stroke and recovery. But also things like aphasia support groups. It may not necessarily be something that a GP is aware of. All of the support groups and all of the organisations that are out there that can help with their patients' recovery journey. So the pathway summarises that and links off to the appropriate website so that the GP can offer the patient either website directions, or write down phone numbers, or print off information so that they can follow the advice that's offered in the pathway. One of the things I found really quite fascinating when I was writing this pathway was the comments that were offered to me about cognition and behaviour. Again, like fatigue and like pain, this can be poorly understood, and one of the things that concerned me was that often patient and carer will simply put up with cognitive changes or with behavioural problems in a post-stroke patient, and they may have the perception that because there has been an insult to the brain, that things that happen to the brain as a result of that cannot be changed or cannot be managed. And of course, the reverse is true. There's a lot that can be done to help patients with both cognitive and behavioural problems. Neuropsychologists are enormously helpful in this space, and again, the pathway does link to the Psychology Association of Australia for GPs to find appropriate and suitable practitioners to help their patients with their cognition and their behavioural problems. And once again, and I have said this previously, but the checklist approach is designed to keep getting patient and doctor go back to these topics if they continue to be identified, knowing that ongoing work will continue to create improvements for the patients, and re-referral is a valid and important part of management. So with activities of daily living, the website speaks a lot about referring to OT in this space, and for vocational rehabilitation in particular is extremely important, as well as logistical and physical considerations which seem intuitive in the space, in the OT space. But what I found really important and what I learned in writing this pathway was that stroke patients can be rehabilitated from a vocational point of view, and that doesn't mean necessarily getting back to work, although it certainly and often it does. But it may be setting a vocational goal like re-establishing a hobby in somebody's life, or making that person able to use a particular device such as a computer, or to be able to garden again, or to do something vocational that will improve their quality of life and improve their capacity to do their ADLs. So in this space in particular, we do encourage GPs to involve rehabilitation, community rehabilitation in general, but in particular OT. It also summarised some of the trickier aspects of post-stroke medicine, things that you don't necessarily memorise but are really important, such as the legalities of returning to drive. So rather than irking the GP by making them look up the Vic Roads document, which is an enormous and cumbersome document, we've summarised it for the GP here so that all that they need in order to give advice about things like driving is in one place and just requires a click. And same with things like sexuality. That can be a tricky topic if you're not familiar with it, and the website summarises to GPs what is an approach to helping with sexuality, and it goes through the various aspects of sexuality, from things like erectile dysfunction, which requires medication, through to psychology, for the psychological impact of becoming disabled or becoming dependent on someone. It certainly talks about occupational therapists and helping persons with positioning, for example, when it comes to sexual intimacy, and we talk about physiotherapy with regard to things like spasticity management as well. So it goes into quite a bit of depth to give GPs the sense that each of the elements that impair somebody's ability to return to sexual activity or return to vocation, each of those elements can be addressed by the appropriate allied health practitioner, and the GP doesn't have to do it on their own. Of course, one of the things that concerns all of us when we're dealing with our post-stroke patients is the wellbeing of the carer, and we have put this into the pathway, acknowledging that carers often don't get well cared for themselves, and so we make a point of getting the GP to remind the carer and remind the patient that the carer should have their own GP, and that there are support groups available for carers of people who have had stroke, and also that a carer can seek out help with a psychologist or a neuropsychologist to help in the caring of their loved one. The other thing that we also recommend in the care of wellbeing section of this pathway is to send carers themselves to rehabilitation centres so that they can learn how to care for their loved one, to get education, and we also suggest that they see an OT. That's been written into the pathway as well, because the occupational therapists can often help the carers learn how to care for and move and assist and guide their stroke survivor loved one with regard to their activities of daily living. The pathway is rich with resources, and we had a lot of discussion about what to add in here, and we tried to keep this as relevant as possible to both GP and to the patient. What you're seeing here is the patient information resources. There's also a separate section for health practitioner resources, and there's also a section that summarises all the literature that was used in the development of the pathway. But I've just put here for you the patient information resources because I think that they're probably the most important. You can click off to relevant websites, but you can also print information straight off the pathway and give it to either the patient or the carer. Enable Me, of course, is a wonderful program. There's also the Stroke Association of Victoria and Better Health channel that we drew on quite heavily to give patients information about stroke and stroke rehabilitation. So I think when it comes to post-stroke care, most certainly we decided that the GP and the practice nurse together can do a lot of this work. I can't emphasise enough how important the practice nurse is in doing this care and in managing the checklist and in screening for depression and in working in tandem with the GP. I'll just pause myself and respond to a question from Amy, who's asked, can allied health professional access these resources? And the answer is absolutely. You can access anything that can be clicked on in this website can be clicked on by allied health professional. I will give you some instructions about how to get access to the website at the conclusion of the webinar. But anything that can be clicked on either for a patient resource or practitioner resource is available to anyone who is a health practitioner. So the care that can be done by the GP and the practice nurse is sort of intuitive. We can manage continence issues. We can often very good at doing our secondary prevention care, often good at initiating and managing things like depression. But there are many things with regard to post-stroke care that need a coordinated approach and need a team, and it is a multidisciplinary team that's required to improve the outcomes for patients. And what this pathway has done is a couple of things. First of all, it recognises that stroke is not managed by GPs alone. Secondly, it's trying to help GPs and patients identify the problems that need to be managed, and then to also advise about how to manage that in a timely and efficient way, and encourage people to continue to manage it, not only to have one attempt at dealing with sequelae and then leave things as they are. And in doing things in a timely way and in drawing upon the right people at the right time for the right problem, well then we know we're going to improve the outcomes for our patients. So if we try and cast our minds into the future and see how can we continue to improve what we're doing in the post-stroke space, I'd like to think that if we start to use tools like HealthPathways Melbourne and we start to become proficient with things like checklists and we start to have a good framework about how to help our patient journey, not just through our GP consult, but journey through the entire health system, that we will see people getting better functional outcomes, improving mood, improving cognition, enjoying their lives more, and certainly managing their ADL better. And of course reducing the risk of having the dreaded second or third event that could result in our patients dying of stroke. More and more clinicians are becoming aware of what HealthPathways Melbourne is, and its use is starting to become more widespread. So hopefully that will result in more streamlined practice out in the community. I have been asked if HealthPathways is being rolled out in other areas of Melbourne or even other states, and the answer is absolutely. There are 17 PHNs that have taken on the HealthPathways product. Certainly, HealthPathways Melbourne deals with northwest and eastern Melbourne catchment, but for example, there is HealthPathways in the west of the state, in the Barwon region, and in many other states of the country as well. PHNs are endorsing and using the HealthPathways website. So I'll just pause myself here and give you some instructions about how to gain access if any of you are choosing to do so. If you have a pen and paper and you're able to write this down, this is the following way in which you can gain access if you would like to have a look. The first way is you can telephone North West Melbourne PHN, and our telephone number is 03 9347 1188. I'll just repeat that number for you. It's 9347 1188. If you have a preference, you can email us, and then we can email you the username and password so that you can start using the HealthPathways live site. And the email for us here is nwmphn@nwmphn.org.au. So you'd be very welcome to send us an email and to get some access so that you can start using the site. At this point, just draw your attention to the references that I've used in order to complete both the pathway and to complete the webinar for you today. And I'm very happy to take questions in the last few minutes that we have remaining of the webinar. Yes, I've been asked to repeat the email address, and absolutely, thank you very much. The email address is nwmphn@nwmphn.org.au. As there are no further questions from anyone in the audience, I just want to thank you very much for tuning in and for the discussion we've had today. I just had another question from Brendan, so I'll interrupt myself. And Brendan's asking, could this pathway act as a template for other disease like Parkinson's? And the answer is absolutely. If you go into the pathways, you'll see multiple pathways that have been written across multiple medical, surgical and psychiatric conditions. I am the clinical editor that is responsible for neurology for my PHN, and Parkinson's disease will be one of the conditions that will be localised for Melbourne over the course of the next 6 months. So that is on our work plan, is to localise Parkinson's for our catchment. And I'm also being asked from Sharon, is there a plan to be conducting any review following the rollout with a view to modifying as needed? That's actually an awesome question. If any of you, when you're using the pathway, would like to offer comments or feedback or suggestions, at the bottom of every page there is a button that says Submit Feedback. So if you see something there that you're curious about, or you have a suggestion about, or comments, or if you're aware that the literature has changed, you can submit feedback and it will come directly to me, and then I respond to that feedback. As far as formal review is concerned, the Pathways get set a review date, and the review date for post-stroke rehabilitation will be 2 yearly. So 2 years from its publication date it will be fully reviewed, and we will invite members of the clinical working group to have a look at its content, and if we need to make changes we will. We also do ad hoc reviews if we are aware that a significant change has occurred in the literature or a new best practice guideline has become available. Then that brings forward a review, and we look at that website sooner than what was originally scheduled. Being asked if Health Pathways is going to be going to Bendigo, and yes, your Health Pathways PHN is Murray PHN. So if you contact Murray PHN, they will be able to give you access. So it certainly has come to Bendigo. Murray have only just started localising their health pathways, so they have slightly fewer pages that are localised at this point. So you may choose to use both the Murray PHN and also the Health Pathways Melbourne website over the course of the coming months. I'm just being asked whether the email address that Rosemary has asked me if she's got that right. Rosemary, yes, that is the correct email address. I'm just going to repeat it one last time just to make sure everyone has the address. It's nwmphn@nwmphn.org.au. So it's that end, nwmphn at nwmphn.org.au. I hope that's clear. Thank you very much, everyone, for attending. If there are any last questions, please feel free to ask me. I really appreciate you all attending. Thank you.